for evaluation of patients awaiting non-cardiac surgery. Nearly 50% patients that are referred to our echocardiography department in our hospital are those awaiting clearance before the surgery. Although useful and informative, one must realize that risk stratification before non-cardiac surgery cannot be done on the basis of echo alone. Several factors are to be considered when assessing cardiac risk. Patient-related factors like age of the patient, the medical history, the functional status, surgery-related factors like the type of surgery, the urgency status, the surgical duration, and test-related factors like the sensitivity and the specificity of the test and its effect on management. Clinical predictors of increased perioperative cardiovascular risk include the major, intermediate, and minor factors. The patients of unstable coronary syndrome, decompensated heart failure, significant arrhythmia, and with severe valvular disease are the major predictors. And the patients of mild angina with compensated or prior heart failure or renal insufficiency or with diabetes are in the intermediate group, while advanced stage of the patient, some abnormal changes in the ECG like atrial fibrillation, STT abnormality, LBBB, etc. fall in the minor clinical predictors. The surgical risk estimation according to the type of surgery or intervention is very important. In this regard, it has been seen that the high-risk surgeries carry more than 5% risk of cardiovascular events, whereas the medium surgical risk is between 1 to 5%, and the low surgical risk is about less than 1%. So patients who are undergoing surgeries like adrenal resection, aortic and major vascular surgeries, pulmonary or liver transplant fall in the high surgical risk group. So timing of surgery is also equally important. In general, acute procedures carry a higher risk of complication than the elective procedures. Uniform timing definitions are unfeasible as the time spans may vary between disease. These guidelines use the timing definition as if surgery or intervention is needed immediately or urgently, or whether it is a time-sensitive surgery. For example, the cancer surgery or the carotid surgery to prevent stroke in symptomatic patients are typically time-sensitive surgeries, where the time window for time-sensitive surgery will vary depending on the underlying disease. And the elective surgery can be performed electively without any significant risk of losing a limb or organ function, and it has less risk of complications. Many factors affect outcome when comparing acute or time-sensitive versus the elective surgery. However, when the best interest of the patient should be considered before deciding on treatment. So active cardiac conditions that are contraindication for non-cardiac surgery include the unstable coronary syndromes, patients of unstable severe angina or recent MI, patient with decompensated heart failure, NYHA functional class 4, patients with significant brady or tachyarrhythmias, and patients of severe valvular disease like severe aortic stenosis with a mean pressure gradient more than 40 or valve area less than 1, and symptomatic mitral stenosis patient with progressive dyspnea on exertion or exertional presyncope. The EAC 2022 has set a guideline for recommendation for transthoracic echocardiography. So in this guideline, class 1B and class 2AB patients are recommended for a transthoracic echo while they are undergoing high-risk non-cardiac surgeries, and these patients have a high NT-proBNP level or a murmur or a low PO functional capacity. However, the patients belonging to class 3 level C, this is not a routine preoperative evaluation. In these patients, a routine preoperative evaluation with transthoracic echo is not recommended. The recommendation for stress imaging. So stress imaging is one of the, has a very high negative predictive value, and a negative stress test is associated with a very low incidence of cardiac events. So the recommendation for stress imaging is before high-risk elective NCS in patients with poor functional capacity and high likelihood of CAD or high clinical risk, and those patients who have previous history of PCI or CABG, the class 1B and the class 2AC, these are recommendations for a stress imaging before taking up the patient for a non-cardiac surgery. However, the patients belonging in the class 3 level C, they are not recommended routinely for a stress imaging before a non-cardiac surgery. So these are the frequently encountered findings which we get in our day-to-day practice while doing echo for patients who are listed for surgery. So left atrial enlargement is a very important factor, because degree of the left atrial enlargement reflects the chronic LV diastolic dysfunction, and patients with L enlargement are prone to have develop atrial fibrillation in the post-operative period. The patients with diastolic dysfunction with a normal systolic function in volume overloaded condition in tachycardia status are also prone to develop HEP-F during the post-operative period if proper care is not taken. Regional wall motion abnormality is generally found in patients with ischemic heart disease. However, myocardial disease secondary to LVBB or stress cardiomyopathy should be differentiated from ischemic heart disease. Valvular regurgitation and valvular stenosis are two important findings that we often see during our echo. So patients with severe aortic stenosis, either symptomatic or asymptomatic, needs valvular intervention before a non-cardiac surgery is to reduce reduce post-operative risk. So, and patients with prosthetic valves should also be examined properly for presence of any vegetation, pannus, or proper functioning of the prosthetic valve before taking up the patient for the surgery. Patients with pericardial effusion, they should be assessed to rule out cardiac tamponade or pericardial constriction, and this should be done by keeping the Doppler, checking the tissue Doppler and also mitral inflow Doppler, and also looking at the IVC collapsibility. Pulmonary hypertension is also one of the most important finding during the preoperative echoes. The presence of moderate to severe pulmonary hypertension is commonly combined with left heart disease. Elevation of estimated pulmonary venous pressure can be a sign of decompensated heart failure. Pulmonary arterial hypertension due to congenital heart disease or idiopathic origin is at a high risk for non-cardiac surgery. So if a patient has right ventricular systolic pressure over 50, invasive hemodynamic monitoring during and after non-cardiac surgery is recommended. So these are few clips of echocardiography that we picked up during our routine checkup. So this is a patient who had come for a checkup for a spinal surgery. Female patient, we can see that the LV systolic function is good. Patient has left ventricular hypertrophy, and there is color flow turbulence in the aortic valve, and when we put the Doppler, you can see there is a severe aortic stenosis with a peak pressure gradient of 72, mean gradient of 39, and we did the Doppler velocity index, which was around 2.6, and this patient was asymptomatic, but yet one should take all precautions before taking this kind of patient for surgery. This is another patient of ischemic heart disease. This patient had a PTCA, and you can see there is reduced function of the basal septum, and we did this patient, we did the ejection fraction from the biplane method, and it was around 42%, and we also did the strain imaging, which was average around 13, and we did check the diastolic function of the patient, and we can see that there is grade 2 to grade 3 diastolic dysfunction with a E by A ratio of 2.3 and the E by E prime ratio of around 17. So this is another patient that of hypertrophic cardiomyopathy with typical mid-septal bulge and apical ballooning, so to conclude, transthoracic echocardiography is an easily available, reproducible, cost-effective tool for preoperative cardiac risk assessment of patients awaiting non-cardiac surgery. However, although very informative in terms of prognostication, it should be emphasized that other investigations are also necessary for a complete assessment of a patient in question. It should also be emphasized in current guidelines, routine preoperative cardiac evaluation by echo is not recommended. Thank you.